You know, when we think about heart surgery, we usually imagine that the story ends right when the last stitch goes in. The heart's fixed, crisis averted, and it's all about recovery from there. But for the medical team, that's not the end at all. In fact, it's just the beginning of a whole new challenge.
Right. So the heart is repaired. But here's the twist. As soon as that patient rolls out of the operating room, the spotlight of concern swings right over from the heart to the lungs. For the doctors and nurses, this is when a second, kind of invisible battle really kicks off.
And this isn't some kind of surprise attack, not at all. In modern medicine, the team starts preparing for this second battle, the one for the lungs, long before the first one, the surgery itself, even gets started. It's all about getting ahead of the problem.
So, what's really going on here? Well, think of your lungs like a bunch of tiny little balloons. After a major surgery, all the anesthesia and stress can make them, well, they can get kind of sticky and start to deflate. They just don't want to stay open. This condition, called atelectasis, along with any fluid that might build up, suddenly makes the simple act of breathing incredibly hard work.
To figure out just how big of a risk this is for each person, the team does a full workup before the surgery even begins. They look at everything: a patient's age, whether they have a history of smoking, other health issues. Even how long the surgery is expected to take plays a huge part in how they plan for what comes next.
And to make it official, doctors use this system from the American Society of Anesthesiologists. It's basically a scale from Class I, which is a totally healthy patient, all the way to Class V, for someone who isn't expected to make it. This gives the whole team a really clear, standardized picture of the patient's overall health, helping them predict exactly what kind of support they're going to need.
And they don't wait around. This proactive care starts right away. Patients are actually taught deep breathing exercises and, this is super important, how to cough the right way to clear their lungs, all before they've even seen the inside of an operating room. These are skills they are absolutely going to need once the surgery is over.
Okay, so the surgery is a success. The patient is moved over to the post-op unit, and this is where the clock starts on those first critical hours. You'd see the patient surrounded by what looks like a symphony of monitoring equipment.
And when I say monitoring, I mean constant, real-time streams of data. The team is watching blood oxygen, the carbon dioxide they breathe out, their heart rhythm, blood pressure, how much fluid is draining. Literally every single critical signal the body is putting out is under the microscope.
And these aren't just a bunch of random numbers on a screen. No way. Every beep, every squiggly line, every reading, it's a piece of the story. It's the body communicating what's happening. And the medical team's job is to listen and interpret that story as it unfolds, minute by minute.
Now, one of the most important tools they have right now is something called PEEP. The easiest way to think about it is like a gentle, continuous puff of air coming from the ventilator that never fully stops, even when the patient breathes out. This constant, gentle pressure is so crucial. It acts like a little scaffold, propping open all those tiny, fragile air sacs in the lungs and keeping them from collapsing. All of this intense support and monitoring, it's all building towards one massive goal: getting the patient to breathe completely on their own, as fast and as safely as they can. This is what's known as the fast-track approach, and it's really a race against the clock.
So what does this fast-track thing actually mean? The goal is fast-track extubation. Extubation is just the fancy word for removing the breathing tube. But getting to that point is a carefully, scientifically managed process.
And the timeline for this, it's incredible. We're not talking about a day or two. The goal is to have the patient breathing on their own within just 2 to 6 hours of getting to the post-op unit. I mean, this is revolutionary. In the past, people might have stayed on a ventilator for days, which actually increases the risk for other problems. This newer approach gets the body back to doing its own thing almost immediately.
Okay, so that brings us to the biggest question of all. If the window is that tight, how in the world does the team know the exact moment a patient is strong enough to fly solo? Well, it all comes down to a really strict 3-part checklist.
First up, the lungs themselves. Is the patient trying to take their own breaths? Are their oxygen levels looking good with only a little bit of help from the ventilator? And is their body's chemistry, its acid-base balance, in the normal range? This is basically a direct test of whether the lungs can do their most basic job. Second, they check the rest of the systems, especially the heart and circulation. Is the blood pressure stable? Any signs of major bleeding? Is the heart beating in a nice, steady rhythm? Because the lungs can't do their job in a vacuum. The whole body has to be ready to support them.
And third, and this one might surprise you, they check if the mind is ready. This is so important. Is the patient awake enough to follow a simple command, like lifting their head? And crucially, do they have a good, strong cough reflex? Once that tube is out, they have to be conscious enough to protect their own airway.
All right, so if a patient checks all 3 of those boxes, they face one final test, the spontaneous breathing trial. For about 30 minutes, the team dials the ventilator support way, way down, pretty much forcing the patient to do most of the work themselves. If they can hang in there for that half hour without any signs of trouble, that's the green light. They're ready.
In that moment, when the breathing tube is successfully removed, that's a huge turning point. It's the end of the machine's job and the beginning of the patient's. That first breath on their own is the true starting line for the road to recovery. And the patient's work starts right away. The torch has been passed. The focus immediately shifts from the team providing passive support to the patient taking an active role in their own recovery.
Now, remember those coughing lessons from before surgery? Time to put them to use. And this is where a really simple but brilliant little trick comes in. A nurse will hand the patient a pillow to hug tightly against their chest incision. This is called splinting. It supports the wound, it helps with the pain, and it lets the patient give a much stronger, more effective cough to start clearing out their lungs.
And from here, the path forward is all about one thing: movement. As soon as possible, they get patients sitting up in a chair. Soon after that, they're up and walking. And all the while, they're being coached to keep up with those deep breathing and coughing exercises. Motion is truly the best medicine for waking up those lungs.
But even with the tube out, the team's job isn't done. Their vigilance continues. They keep a close watch for any signs of trouble, things like pneumonia or a collapsed lung, just to make sure all that hard-won progress stays on the right track.
When you really step back and look at it, this whole process is just an amazing, finely tuned dance between science, technology, and just good old-fashioned human care. It's a modern marvel that shifted the focus from just fixing a single organ to healing the entire person. It really makes you wonder, right? With things like AI and new monitoring tech just around the corner, how is this journey going to change next? Could it get even faster, even safer?